Tēnā koutou katoa.
Nau mai, haere mai, tauti mai. Welcome to Hey Ara Waiora, a three-part webinar series that explores health equity from a Māori perspective. I'd like to invite Gilbert Taurua to open up this evening with a karakia. Kia ora, Gilbert.
Tēnā koutou te whānau I o te mutu, tēnei te mei, tēnei te mihi tōtoko no te kaupapa o tā karakia te matanga. Tēnā koe he pā I honori hi kororia mō ngā rongo ki te whenua, aho mai, te maramatanga taranga Māori I te kaha me te aroha, mō tēnei rā tūturu whakamau a ka teina, haume e, hui e, tai ki e.
Kia ora, Gilbert. Kia ora, so my name is Tracy Potiki and I work for Taurua and a project lead for Whare Tukutuku. Hey Ara Waiora webinar series explores what is health equity, how we can get there, and it's part of a three-part Ara Waiora series, and this one will focus on the future. What if our health system continues to fail some of us? The webinar running order will be an introduction of Whare Tukutuku, our guest speakers, and the subject matter our guest speakers will be talking to, followed by a 10-minute presentation from each of our guest speakers. Then there will be a 30-minute Q&A for anyone who has joined us this evening to ask our two wonderful presenters anything they like about the topic. So Whare Tukutuku is a collaboration between Taurua and the New Zealand Drug Foundation. And we're developing an approach to alcohol and drug harm that recognises our communities and our whānau as part of the solution. The goal is to build capability within our communities. Whare Tukutuku understands that within the whakapapa of our communities is incredible potential and the ability to create a new workforce. Our guests tonight, Gilbert Taurua and Dr. Rawiri Jensen, will be talking about the future. What if our health system continues to fail us? Gilbert is nā pui mea te atahaua nui. Gilbert has 3 decades of experience across a broad range of healthcare sector roles, half of them in senior Māori positions. He's currently the Chief Māori Strategy and Improvement Officer for the Southern District Health Board and Well South Primary Care Network. Gilbert holds a postgraduate diploma in social work from the University of Canterbury. He was born in Christchurch. He's married with 3 beautiful children, and he understands the dynamics at play in providing quality clinical care within a changing physical environment, he has significant governance experience, including as principal advisor for the Māori New Zealand Drug Foundation, National Māori Manager for the Alcohol Advisory Council of New Zealand, and Director Māori Health within the Whanganui District Health Board. So, kia ora Gilbert, lovely that you could join us this evening. Dr. Rawiri Jensen, Ngāti Raukawa. Rawiri has been a GP for 2 decades and currently practices in Papakura, South Auckland. He is also part of the executive team for the National Hauora Coalition. Dr. Jensen provided clinical teaching, te reo and tikanga Māori programs for Māori health professionals throughout the country for several years. He has been chairman of Te Atarangi Trust, a national Māori language organisation, and chairperson of Te Ohorata or Aotearoa, the Māori Medical Practitioners Association. He self-published Māori Medical Phrasebook in 2006. Dr. Jensen's main focus now is providing clinical leadership towards Māori health equity as a general practitioner and clinical director for a primary healthcare organisation. Kia ora Rawiri, lovely to have you with us this evening. So what will happen now is I'll invite Gilbert to do a 10-minute presentation on the topic, and then invite you, Rawiri, to do a 10-minute presentation on the topic. Gilbert, would you please kick us off? Kia ora.
Kia ora rā. Thank you, Tracy, and yeah, great opportunity to have a kōrero, I guess, about some of the, contemporary issues specific to the treaty. So I'm a Taurua from Waitangi, and so my whānau still believe that, you know, we are guardians of the Treaty of Waitangi, and I was brought up, really, my nini lived behind the lower marae, Te Tii marae in Waitangi, and so I spent many years you know, in and around, I guess, not only the treaty grounds, but obviously the lower marae. What I was always fascinated about, actually, is that everybody tended to drapes up to the treaty grounds, and clearly our nani, Ara here, really grounded us and showed us where actually the treaty was signed. And so the treaty wasn't signed on the treaty grounds; it was actually signed, you know, on that camping ground just by the lower ground where those carvings are now. And so, not saying it's a fraud, but obviously our national memorial doesn't necessarily reflect where those chiefs signed the final part of that document. I was, I guess, engaged in the social work sector, primarily working for, in the early days, Department of Social Welfare, and that morphed into, you know, child, youth and family. And so obviously at that stage, the 3 Ps was, I guess, reflected in regards to how at that stage we saw the interpretation of the Treaty of Waitangi. Those 3 Ps obviously being partnership, protection and participation. And although they were great principles, I guess that what we've seen over the decades, at least that I've been involved in the social services and health sector, really became rhetoric, and there was no real application, I think, in regards to those principles. Now, Rawiri, obviously, with his many roles, will probably talk to some of the issues of the recent Treaty of Waitangi tribunal claim, at least at this stage 1, looking at the issues specific to primary health care. Clearly that document, while that process articulated that primary health care has failed Māori people, I appreciate it's bigger than just primary health care, but though that document, I guess, interpreted a different approach to how the treaty should be kind of considered, and those principles, contemporary principles, are clearly articulated in the document, and it's probably changed, I think, the model around the 3 Ps to a different kind of approach. So I guess the first principle that the claim considered was issues specific to tino rangatiratanga, and so I guess with that, it's closely associated with mana motuhake, and the empowerment of Māori to design and deliver and monitor health and disability services for our people. There's a lot of conversations going on at the moment around equity, and I think that equity potentially, at least within a Māori perspective, may be being misinterpreted, but clearly from a iwi Māori perspective, equity is specific to the treaty, and the associated equity issues specific to that are clearly a driver, not only for health policy at the moment, but I guess right across the government sector as we speak. The third principle that was interpreted as the issues around active protection, and as we clearly know, Māori have not been effectively protected against a range of health-related issues, and so obviously that principle in the contemporary context has, I guess, redesigned how we consider the interpretation of the treaty in our current in our current environment. The fourth principle is specific to options, and I guess that is specific to Māori being empowered, I suppose, to be able to choose their own choice of service. And I clearly am aware that our Māori health provider sector provides a number of opportunities in an alternative way that Māori can, I guess, actively look to reduce the burden specific to some of the health diseases, obviously, that we face. The last principle specific to this Y2575 claim is around partnership. And it's obviously clearly a challenge, I guess, for particularly government organisations to partner, not only with iwi organisations, but those in the community, those taurehiri communities that quite often are perhaps more at risk at times in regards to iwi boundaries. But clearly I think there's an expectation as we move forward that the Crown and its associated entities does clearly need to partner with clearly Māori community, hapu, I guess whānau and iwi in regards to reducing the disparity that we face. So as we all know, this is a contemporary kind of interpretation of the treaty. I appreciate the treaty is a historical document and its relevance today obviously still does have relevance. However, it's always obviously a challenge, I suppose, for documents that were produced so long ago to have a real impact in regards to what we need to be doing at the moment. But I do understand that the Crown, and again, being, I guess, driven by the Y2575 claim, may look to amend the health and disability legislation to further reinforce these particular principles which have been interpreted more recently, and clearly the expectation that I guess Crown entities, that's specifically where this relates, but obviously all the associated NGO organisations, PHOs, also have an expectation and an obligation to be looking at reducing health disparity. Yeah, so those are my initial thoughts, Tracy. A pathway to wellness, I think potentially it does. But of course, with principles like tēnā rangatiratanga and mana motahaki will clearly be a challenge for Crown entities, because obviously they will need to look towards better sharing of not only resource intel and policy, and with the dominant culture the way it is, this will be a clear challenge for our country as we move forward. So my thoughts at this stage, Trace. Kia ora.
Kia ora. Ngā mihi Gilbert, thank you for sharing your thoughts, and I'd like to hand it over to Dr. Rawiri. Kia ora, Rawiri.
Kia ora tātou. Me taku mihi kia koutou o Whare Tukutuku i hanga tēnei whare ka me ki, tēnei whare kōrero, tēnei pō, engari tēnei kaupapa, nā koutou tēnei i waihanga nō reira, ka mihi kia koutou. O tira me mihi hoki kia koutou e tūhono mai nei, tēnei pō tēnā koutou. Hey, great to be here. Whoa, webinar. Oh, there's a couple of dozen people watching us, which is cool. So peace everybody who's joined in. Gilbert's provoking me, man. You know he is. He's telling me things, and I got to respond to them, and I just got to pause and back it up a little bit and go, okay. So yeah, Y2575 is a big important kaupapa claim, and it's been divided into stages. So primary care, and so I'm a claimant. I'm with 2499, which is Te Ora Māori Medical Practitioners. We're claimant in it. We're not one of the lead claimants in stage 1, but I work for the NHC, who is a lead claimant in stage 1. So, interesting times. And so that in having a kaupapa inquiry, it's a provocation to look at what we've got done so far. And so we I think we want to look at that in a context that goes back probably 160 something years. But if we look at recent history, the establishment of the tribunal and the early claims, and then we end up in a point where between the Waitangi Tribunal and the appeals court, we end up with some principles. And so those principles were contested at the time, and they've since been found wanting. And so the 2575 interim report takes it a little bit further. But, so I want to disagree a little bit with what Gilbert's saying, that these are interpretations. Actually, the revision of the principles is based on evidence. So we had the partnership protection, we had those kind of dynamics asserted 30 years ago. And the evidence is that that did not get us into a place, we're not at a place where we are having our rights as tangata whenua asserted, enabled, enacted. We're not able to act with rangatiratanga. We don't have mana motuhake. So the evidence around that presented at the tribunal itself is reflecting on its previous principles and has gone further. And I welcome that. And so, to be clear, I was at a conference in Wellington earlier today, and at that conference, let's be absolutely clear, the 3 Ps is not acceptable. The tribunal itself said in its time that was the intention, and it is no longer acceptable. So we've moved on from that. We've stepped up the game. And so I like the idea of calling out the principle of mana motuhake tino rangatiratanga. That is the fundamental right that we are asserting. And, so the rest of it, the 5, you've got to know the 5 principles, absolutely. So that's Judge Stephen Clark, and he also gives us, I think, permission and license and authorises us to design, deliver, and monitor the Crown. So there's no doubt we have a right to monitor the Crown, and we must monitor the Crown, because if we don't do it, they ain't doing it. That's clear. They have not monitored themselves. TPK, and at the hearings that we had in Tūranga Waiwai, TPK admitted that in 2014 they stopped monitoring Crown agencies. Despite the fact that's in the legislation. So we're not putting all of our hopes into the legislation says. We're not putting all of our hopes into the policy says, because we've had legislation, we've had policy, and that hasn't got the job done. And so my assertion is that we will be relentless, we will be deliberate, we will be determined. We will not stop until we achieve tino rangatiratanga, until we achieve hauora for our people. And Gilbert does kind of touch on some of the complexities of that. I get it. I'm in Auckland, and we have some of the DHBs, the Crown agents, want to recognise one iwi as their treaty partner. Wake up, smell the coffee, people. That ain't going to cut it. Because in Auckland, we have hundreds of thousands of our people living in this city. And you cannot say that you're going to treaty partner with one part of it. Yes, you have to have a treaty partner called the mana whenua. Hell yeah. That's absolute. But you cannot go, we're going to do that and that's it. We're not having treaty partnerships with, mātāwaka. So Gilbert correctly, I think, identifies the importance of that. But let's acknowledge there's a complexity to that. And then there's a few areas which I think, and we want to have kind of a really big ideas conversation. There's a couple of areas at least that we ought to go, and what a fantastic achievement that we have, and we've got to name it, right? So I want to go number 1. Stats NZ will confirm shortly that the New Zealand Māori population is, and they're going to come up with a number, right? So we might be arguing whether it was 684,000 or if it's 860,000, something like that. Because, you know, I'm just saying, I've got to call out stats. New Zealand, they lost 49,000 Māori people in the 2013 census. They lost a population the size of Gisborne, right? So we've got to be really critical of that. That's not acceptable. You know, I want to ask them in Parliament, how many times have you lost 49,000 Pākehā people? Well, the answer is never. And that's not acceptable that we have a failed census. You know, we have a right. So the Māori data sovereignty movement, Te Manararonga, that's really important contribution. But having said that, let's acknowledge more Māori living today than ever before. The low point in our population is probably 1901 at 47,000. And the Māori population has grown every year since. There's this incredible success that we ought to own. We have survived. Yes, colonisation has happened and continues to happen to us, but we continue to survive. We've got work to do if we want to thrive. But number one, Māori population is big and beautiful. Then we've got some other things that I think we could call out, and you know, I'm going to narrow it down to Māori medical practitioners. But my assertion is that we are the first jurisdiction in the world to achieve demographic proportionality of entry into med school by the Indigenous population. We're the first jurisdiction in the world to achieve demographic proportionality of graduating medical students for the Indigenous population. That's sensational. It tells us something that we can do this. We can. So I want to have a kind of positive thread in what we're doing. We're going to talk statistics sometimes that are really challenging, and some of the statistics are dreadful and terrible, and will feel like they're impossible to overcome. But we must never give up. The impossible will be done, can be done. And then, so the last thing that I think kind of to situate our kōrero tonight is to go and look what happened at COVID. Yeah. So this virus is complex and challenging, and Māori communities stood up, and Māori communities and Māori whānau and iwi and Māori health providers and Māori community organisations actually did remarkable, fantastic things, things that we can be proud of. And we did it in a racialised environment where we are being portrayed as problematic. We're being portrayed as troublesome. You know, the checkpoints are an act of protection for our communities, and they were portrayed very negatively. We've got to resist that. We've got to own that space. The checkpoints were an act of tino rangatiratanga. The checkpoints were an expression of sovereignty. And to bring it back to the treaty, you know where that comes from? Tai Hakure jury in the Muri Whenua fishing claim. And in that claim, it's a beautiful document. He's collecting all of these old kōrero about fishing rights and stuff like that. And the assertions that people were making were not that we own the ocean. They weren't asserting that we own all the fish, but they were making assertions about tino rangatiratanga. And so in there, he does talk about the kind of assertions that we might have if you think of an area of coastline with a bay, and there might be a promontory here and a point here, and between this point and this point, this whānau has rangatiratanga over that fisheries, and they have the power of when to say it's your turn to fish, or when it's nobody fishes at this time, or you know, people from visiting can come in and we fish together sometimes. But what he distilled was that there was a power to say no. That is, the power to say no is an act of tino rangatiratanga. And if you recognise that in terms of fishes and fisheries and the ocean, then I think we should also recognise that in terms of our communities and our areas, our tribal rohe, where we go, put up a roadblock, put up a checkpoint, but we have the power to say no, don't come in. And so I thought, you know, there was a whole lot of amazing things that happened with COVID, really positive, really strong, really sovereign assertions, and I love it. So that's my opening comments. Over. I'm going to read the chat now. Over.
Kia ora, Rawiri. Beautiful kōrero, and I love some of your statements because they're nice and clear, like never give up. And you know, we have a choice about whether we're exercising that sovereignty, that we are not kind of, regardless of the complexity, we're not victims of the state, you know. So I really, really appreciate that. And how lovely that you're both sort of entered into the treaty frame straight away. And I'm interested in if we're breaking some of that stuff down, what might that look like in an alcohol and drug conversation space? Anyone want to take on that?
Oh, yes, please.
Say no, isn't it the power to say no? The work that you're doing, Tracy, in this, you when you opened it, you said one of the things that we're trying to do is create and empower and enable our communities to be safe from drugs and alcohol. You know, well, that's what I heard you say. And so isn't that a beautiful power? And I've seen it exercised in Manurewa, where community action said, no more liquor outlets in our area. That's a beautiful, powerful statement. And we should be developing and supporting that. And how do we get community action so that we can take these sovereign actions? That's my response. Back to you, Gilbert.
Oh, kia ora, Rawiri. Wasn't the referendum an interesting debate, and obviously reinforces that we're starting to have some mature conversations around the fact that drug use is a reality for a number of our communities. And what was really reinforced is that Māori are often, I guess, the victims to the enforcement approach in dealing with this issue. So we've got to uncover the realities that people do take drugs. And I've been amused today actually to see the police in Queenstown have just arrested a whole range of people based off actually wastewater testing that they've been doing recently. So I'm not sure necessarily that's going to reduce the burden of drug use in that particular community. So we have to think and we have to debate. And I know that within a Māori kind of community context, discussions around drugs is a complex beast, but the current system isn't working. Criminalising people doesn't work, and so therefore I think we are on the cusp of some potential change. We know that if we were to reallocate the money that's going into enforcement specific to drugs and put that in, in a proactive, positive kind of treatment and general support approach, we would potentially reduce the burden significantly. We know that primary healthcare isn't necessarily well positioned to be able to deal with the issues associated with drugs and drug use, and it's time that we appeal the Misuse of Drugs Act, and we should be removing all criminal penalties for possession, use and social supply of drugs. And so yeah, it's going to be really interesting to see where that debate goes with the referendum, but clearly the current system doesn't work and Māori are the victims to this approach. And as we know through alcohol was used by the colonisers, I guess, to break down our culture, our people, and as we know, a number of pieces of legislation. And land, for example, was sold as a result of some of the impacts of drugs and drug use. I could talk about this for hours, but anyway, okay, tapai.
Tapai, thanks, Gilbert. I think one of the things which always impresses me and astounds me is just how resilient we are. Despite everything, it blows me away, the resilience which comes out of the struggle, and it just brings out the very best activists in me. Rawiri, would you like to answer this question from the kuia? And she's asking, is it a reality that in the future that the MOH will be devolved and we Māori will be directly funded to look after the health, tino rangatiratanga of our own? Would you like to make a comment on that for the kuia?
Well, it's not a reality, but it's a beautiful moimoia. Kuia, you can see the future. That's a beautiful way of putting it. Imagine that we did that. So I think of it as a thought experiment, and we're going, currently in our health system, we spend $15 billion a year, right? And some of it's Ministry of Health, and then some of it gets divided up into DHBs, and less than 1% of it goes to primary health care. But the thought experiment is to say, if we did it a different way, and we really truly did this thing of saying whānau's at the centre of this, then, inside the NHC where I work, we're doing these thought experiments about what an independent hauora agency would be. What would it look like? And one of the things that we think it would do is commission with whānau, directly with whānau, co-commissioning, right? And, I think previously it was really challenging, really difficult, but technology is opening for us opportunities to be much closer in planning and organising and delivering and procuring services directly for whānau. So Whānau Water Commissioning Agency, during COVID, did that massive effort of getting a whole bunch of things organised in boxes called hygiene packs. So in Papakura, where I work, thousands of these boxes, and again, driven by this principle called manaakitanga. We didn't go, we're only doing it for the people who are registered with our service. They went street by street by street in Papakura, offering it to every house. And some people said no, and some people said yes. So, and then not long later, then they've got food parcels, and they're delivering these food parcels. And some people said no, and some people said yes. And they're paying attention to what the whānau are saying. And some whānau go, not like that last box, is it? Because we don't eat that shit. Can we have something different? And so paying attention to that. And over time, those food parcels became designed around the whānau need. And so we can do that really quickly, I think. And then if you imagine that up on a bigger scale, what would that be around a whānau need for their health needs? And so anyway, that kuia's onto it, right? She can see the future, and she's seeing the future because it's coming from our past. It's from our past, and it comes into our vision. And that's exactly what we got to be doing if we get into a place where we are redesigning. So the real provocation is, how do we deconstruct the Ministry of Health in such a way that we can get resources that we can deploy for our health needs? And that's our challenge. That's a big one. That's really problematic. And so we've got to put Gilbert on the spot and go, okay, so you're the Chief of Strategy for Southern DHB. And I don't know, I'm guessing you've got a DHB that gets, I don't know, close to $1 billion. You get $900 million a year or something like that. And how do we deconstruct that pūtea in such a way that we can make sense of it in whānau, hapu, and iwi, and we can deploy some of that resource to meet our health needs, and whether that's drugs and alcohol or oral health or mental health or whatever. So, but beautiful question, beautiful.
Gilbert, would you like to have a crack at how would you deconstruct like the organisation you work in? What should it look like if it was really going to put whānau at the centre of what it does? What could it look like? Take your time.
Yeah, it is. I have to do the preamble. My comments are my own personal comments, and not that of the employer. So, I mean, we're on the cusp of some significant change, as we all know. I think really we're finally starting to understand that the current system isn't working, and I guess there's been several reviews more recently. I think we talked about Y2575, and it'll be so interesting to see what happens with stage 2 of that. But we saw Ara Waiora, the government inquiry into mental health and addiction related issues. Clearly system isn't working for our people. We're seeing some really cool documents like Taurua Taki Manaki, which is excellence in emergency departments. So I think there's starting to be a real growing awareness that, I mean, emergency staff obviously being a central point of contact for Māori. so saddened to see that, you know, 1 in 5 cancers are picked up in emergency departments. So clearly, primary healthcare isn't reducing the burden. And of course, we've seen the recent Te Ora cultural safety baseline data report as well, which clearly again reinforces that the primary healthcare sector needs to do some significant work in this space. So 20 DHBs. You know, 5 million people. Clearly, we have duplication and issues going on, and so obviously the Heather Simpson Health and Disability System Review clearly is articulating a reduction in DHBs. I kind of support that approach primarily because obviously our country is too small, but you know, there's clear evidence that the system isn't working for Māori. You know, Rawiri's clearly articulated the issues around mana motahaki and tino rangatiratanga, and it's about time those in power start to devolve obviously some of those responsibilities. Yeah, any act where one imposes one will upon another, I think that was Gandhi's quote, is a form of violence. We are being violated. We have been violated. We continue to be violated, and we die early. And I see that in a day-to-day reality in the work that I do.
Kia ora, Gilbert. It's yeah, really a good reply. I was thinking about you know, like we're pretty familiar with the failings of government and the poor policy which gets in the way of our innovations and the what has been termed what's that fluffy term they use, Rawiri, for racism?
Unconscious bias.
Thank you. Unconscious bias getting in the way of some stuff. So what would it take for that to change? Like, and also, what are your thoughts on what a future health workforce might look like that is doing what it's meant to do, which is attend to the needs of the whole of society, not just proportions of it? What might that look like? Rawiri.
Yeah, complex, eh? So, and the problem, oh no, it's not a problem, but let me just own it. I'm trained in Western Orthodox medicine. So, which actually, if you take that, it's really building a system that addresses illness, which is not wrong. I mean, you know, people are ill, let's do some stuff, right? I get it, but it's not enough. You know, the whole water system, which we're advocating in the NHC, in the National Whole Water Coalition, the whole water system is much more than the absence of illness.
Yeah.
And actually, you can have whole water even if you've got illness, to be honest, eh? You can have whole water because you're connected with your whānau, because you know who you are in this world, because you know, you can go to your marae, you can see your mokopuna, you can, you know, I mean, just there must be thousands, millions of ways of describing things that are hauora. And yes, that is what we should be aspiring to. And yes, that is what we should be organising to. And we still need to have a illness treatment management system, but that illness management system also has to be coherent and understandable to our people. That's why, you know, Māori providers of general practice, that's a really important contribution we make to our communities. It makes sense. If you have people who are looking after you who are, we say culturally concordant, but they get you, you get them. When we talk about gout or heart disease or cancer or you know, any number of things, we can be understood and we're understandable. That's important to have that. But we need much more than just an illness treatment prevention system. We want whole water. That whole water starts to talk to, you know, a whole lot of other things in terms of being connected and achieving our aspirations in the world. So yeah, it's a really big question, but I mean that's what we're here for. You know, we're here because we want to be good ancestors. You know, we can celebrate our ancestors. We can go back and back and back, you know, 20, 25 generations, 30 generations. We can whakapapa all the way back. It's a beautiful thing. And we've got a responsibility for the generations to come. And so we're not afraid of doing things which are long term. We better be doing things which are going to be long term. And sometimes we have to do things which are here and now. We have to look after the immediate needs of our whānau, if that's housing, if that's food, if that's treating a disease, all of that's great. We've got to do a much better job of intervening around income and employment and education and stuff like that. That's, you know, I mean, just look at the genius of Kohanga Reo.
Right.
You know, look at the contribution of kura kaupapa Māori. Look at wharekura, look at wānanga, you know, just absolutely amazing. And then let's go modern. Look at Māori TV. It's bloody fantastic. Eh? You know, we've got to do all of these things. Over.
I remember when Māori TV went live, and I remember feeling like it was a dream, like someone imagined this in the future, and how amazing that is, and all the people who got, you know, who were part of that that journey, that fought to make it happen, and just how amazing, you know, our people are when, you know, when they're just given a bit of an opportunity to do something. I just love that. So yeah, thank you for that. And like what I like at the moment, one of the wero that you put down earlier, Rawiri, was around Stats NZ and there being some discrepancies in the collection of data. What do you think? What do you think the future? What do you think the population future will look like in, say, like 20 years' time, in terms of growth, Māori population growth, and how are we planning our healthcare systems to accommodate for those population changes? All hard questions for you boys tonight.
Well, look, one way of answering it is, I'm not sure how old everybody is online, but you know, I'm reasonably old. But in my lifetime, we are going to see 1 million Māori. Actually, sometimes I want to make the assertion there's 1 million Māori today, because I think it's 864,000 Māori living in Aotearoa today, and I want to reach out and include all of our Māori living in Australia, and there's another 50,000 Māori living in London or something like that. I think we are 1 million today.
Yeah.
So we are still growing as a population. You know, like Pākehās are not even reproducing; they're not even at the reproduction level. Their fertility rate has fallen below 2. Right? They're not reproducing themselves. That's cool, no problem. I'm not criticizing. I'm just noticing it. All right. And the Māori fertility rate is still intact. We're growing as a population. That's a beautiful thing. So, as a result of that, there's a number of things we've got to do, and what, you know, there's a whole lot of preparation and organising, and we want to have unreasonable expectations from the system that we're going to do treaty claims, and we're going to get resources, and we're going to get programs of action, and okay, all of that. We've got to do all of that totally, and that's across health and education and all sorts of things, right? And we've got to do a hell of a lot more in housing, and we've got to do a hell of a lot more in income. I don't know. There's one of the young people there is in Maniapoto asking a question about, which is a beautiful question. What are we doing to make sure that every Māori is in KiwiSaver?
Oh.
You know, what are we doing to make sure that we are building a trajectory for our people so that when they get to 65, hell yeah, they're in a good space. So I'm looking for equity in a whole range of areas, or better than equity. Okay, so equity or better in 20 years means that 43% of our people, when they reach the age of 65, own their own home with no mortgage. That's what we're looking for. Okay, I'm looking for equity that we can describe equity in terms of the number of people who have got a educational qualification. In 2040, we've got equity there. In 2040, we can talk about what equity looks like in terms of income, educational qualifications, housing ownership. And so if that's true, we've got a lot of work to do. We've got things to do. We've got to look after, you know, all Māori who've got a job today and they're kind of mid-career or something. What are we doing to support them in their career trajectory? What are we doing to get them so that they are achieving really remarkable things between now and 2040? And so I think there's a whole lot of activity that we've got to get busy on if we really want to see this amazing 2040, 200 years since the signing of the Treaty of Waitangi, and we want to be celebrating. You know, like I'm absolutely clear, we're available to protest if we don't get this shit done. But we don't want to be protesting. We want to be celebrating because we've got equity sorted on, you know, young people and employment, young people in education, and young people and, you know, health, and middle-aged people and health, and middle-aged people and housing ownership, and old people. So imagine that we looked after everybody who's 65 today. They're going to be 85 when we celebrate 200 years of signing the Treaty of Waitangi. Well, we got quite a bit of health work to do for them. That's for sure. But you know, we want to kind of look across our whole population and describe what that journey looks like from here to 2040. And that should guide us, because we're going to deconstruct it back from 2040 to, so what do we need to do now, tomorrow, next year? Yep. So that's, I mean, that's a plan. And I think every iwi is starting to figure that out. And every iwi, Maniuputs will probably already, they probably want to come online and tell us, yep, we got a plan for the next 20, we have a plan. This is what we're going to do. So, you know, that probably take quite a while to text it in, but anyway. Ka
pai tō kōrero. Gilbert, do you have a view on the big
Wow,
picture?
awesome kōrero. I'm loving the chat coming through. Kia ora, Ian. Maybe you're a whanaunga from Davis. I see maybe you're a whanaunga, but listen, we've got to brown up the workforce. We've got to get our equitable access to the resource. We've got to you know, build that iwi voice. I think is critical, and as we all know, post-treaty settlement approaches and stuff, a lot of money has gone on wealth generation, but actually there's been limited investment in the health approach. I appreciate that's probably an Article 3 related issue, but iwi do have the power. I do understand the next iwi chairs Forum and Waitangi will probably for the first time really talk about some of the specific issues to do with health. Clearly, current system isn't working. I see on a day-to-day basis our people dying, I guess, from a whole range of preventable diseases, and it's time to change, and it's time to share the power, and it's time for us to have equitable access to resourcing. And so this really means a complete exchange of power. We all know our Māori providers up against it in regards to the demands against their services, and you know, this health and disability system review talks about increasing funding to Māori for Māori providers. That's going to be a big challenge for them, because obviously that will mean that they will have to you know, devolve power and resource to make that happen. I'm still a bit skeptical about what that might look like. I could talk about this for hours, as Rawiri's kind of articulated, but we've got to brown up our workforce for a start off, and we've got to stop people coming into hospital, which obviously means primary health care needs to pick up the game. From my perspective, working across both, I guess, primary, secondary and tertiary, primary is out there on a limb. There's no integration at all necessarily with the wider health system. And as our Māori providers have done for many years, they've been integrated in the approaches that they've, I guess, had to find themselves in. So they'll quite often hold health contracts, but they'll also hold corrections, MSD, oranga tamariki, you know, a whole range of other contracts. And so when they talk about tier 1 services within this review, it's a no-brainer that the approach to reducing health disparity is an integrated approach with other government departments, not just health.
that's a really interesting point that you're raising around this idea of integration. I think it's worth giving some thought to. And here's my take on integration: that a health system which is caring and putting whānau at its centre doesn't expect Māori to integrate into that health system. They integrate into us and how we are and the way we do things. And I think that that's been the issue with this idea of integrating, that Māori then become a bit of a tag on, a bit of a brown clip to this idea of integration. We need to flip that on its head, And I also want to pick up on some of the kōrero around equity and some of the challenges that we have in that space. And like we just come through a referendum, and a slight majority of the population voted no to legalise cannabis, and yet we know that that Māori are still ending up before the courts as a result of that decision. What do you think? What do you think our court system will look like in, say, 10, 20 years from now, in terms of how it deals with our whānau and our whānau who have complexities around their drug use? What do you think it might look like? What does it need to look like would be more accurate?
Well, I've been doing some thinking about it, and I was at a hui with Stats NZ and a whole lot of government agencies. Te Manararonga, the Māori, National Māori Data Sovereignty Movement, had a big meeting with the government agencies and stuff. And so there was, it was really good. They had 17 government agencies there, but my provocation to them is that I think that all Māori data has to have Māori data governance, right?
Yeah.
And it seems like a reasonable demand, eh? And anyway, fuck it. If it's unreasonable, we'll suck it up, because it's a brilliant demand. It's a sovereign movement, right? I want to live in a jurisdiction that has Māori data governance over Māori data. And that's not just in government data. That's not just Stats NZ and the census. I mean that seriously. We want to live in a jurisdiction in which Māori data has Māori data governance. So you imagine you go to the supermarket, Countdown supermarket, beautiful. They got all the bilingual signs. I love it. I'm loving it. And they are tracking you right now on how you go through the shop. Go to the wine section first. Oops, hang on, go to the veggie section, of the meat department, the fish department, all of that stuff, right? And that's cool. I get it, because they're in the business of trying to understand their customer. But what I'm saying is that if they collect Māori data, then we have to have Māori data governance over that. So imagine we were in some sort of partnership with Countdown. It's a private company, doesn't matter, because you're in Aotearoa. Here's the rules, Countdown. Here is the rules. You've got Māori data. We need to have Māori data oversight. And so we're looking at the data, and, I want Countdown to be a successful, good business, being groceries. I mean, groceries is important, right? But if we understand what Māori shopping experiences look like, and we can design that store so that we make good choices about fruit and veggies and fish and all of this stuff, and we spend the money. That's the thing. Countdown, just chill, man. We're going to make sure that everybody spends the money. You're going to be okay, Countdown, but they're going to spend the money in ways which is also good for their wairua, good for their tinana, good for their whānau. Now that's what I want to live in, that jurisdiction. So here, this is sorry, I'm rambling, but it's the provocation is to think about data. And so now you ask me to describe what I think the future is with police and justice. So in the network stuff that I do as a clinical director, I'm looking over data for a whole lot of our clinics. And I know that we can track and trace, and we can present data back to people in a way that will change their behavior. I want to do that with judges. Judges think they are separated from the rest of us, and none of us can criticize their work. Well, you know what? We can collect data on them and give them data back, and talk to a particular judge and go, you know what? You're convicting Māori a little bit more than everybody else. We're just noticing it. What are you doing? What do you think about that? Or the average judge is sentencing Māori to community service like this and prison like this, and you're doing it differently. Why is that? We want you to reflect on that. We want you to change your behaviour. And so we can use data for judges to get them to change what they're doing, to get more mindful, because they've got inherent biases. They've got racism running around in their head. Some of them think that Māori are dangerous. So they see Māori and they go, oh, well, probably guilty. Oh, they see Māori and go, oh, better send you to jail, all that shit. So, but we can change that. We got to change that. You know, we got through COVID because Jacinda said, let's be kind. And I go, that's lovely. That's beautiful. Let's be kind. But we can use that. We can change. We can use culture to change people, but we do have to have the data. I do have to be able to be on top of that data and show them this is how they are behaving. So we do that with GPs. We show them what is their prescribing data. This is, you're prescribing statins to Māori, much less than you're prescribing statins to Pākehā. And this is an issue in terms of cardiovascular disease and survival and lives. And so we can provoke these GPs because, and the other thing is because they know that I'm watching, they change their behavior. There's a science called Hawthorne Effect. People change their behavior if they know they're being watched. Well, shit, I'm in favor of that. Let's do that with police. You know, that part of the Black Lives Matter thing was we're going to film police and you got to have a camera on your chest and we got to detail that and we'll be able to talk to cops who arrest Māori more than give warnings. You know, like give warnings, man. Get over yourself. You do not have to arrest Māori. They're not that dangerous. It's a driving ticket, bro. It's a cannabis joint. Crikey, get over yourself, you know. But to help them get over themselves part of this, we have to show them their data, not national data. Hey, I need to show them their exact data and say, this is you, this is everybody else. Get yourself sorted, please, judge or police officer, whatever. Because I know that makes a difference in the health system. So that's my fantasy. And so we're at this meeting in Wellington. It was about, I don't know, 6 weeks ago. And the police guy, he's up for it. He's interested. You know, let's do an experiment. Let's figure out how to do this. So yeah, that's our future. And that's a near future. So in 5 or 10 years' time, we've got to have changed that thing. You know, even though the Labor government told police, look, don't arrest people for marijuana. If it's a health issue, just tell them to get the health issue sorted. Support them to reach out and get some help for their health issue. But did that change? Well, it changed things for about 6 weeks. And it didn't change things enough. And police are still arresting our kids. You know, my understanding, there's 2,500 men in prison now for with a trajectory from minor drug offences. You know, that is thousands of kids who do not have their dad in their life, who will not be there at Christmas time. You know, it is harmful. This drug shit is harmful. Arresting our young men for minor offences like a joint or speeding ticket or driving without a license. We can fix that. We must fix that. That's like a priority. That's a really important priority.
Ka pai tō kōrero. Awesome. There's a pātai come through from a rangatahi who wants to know, what does brown up the workforce mean? What does that mean?
Aroha mai, yeah, well, when I talk about brown up the workforce, we need more Māori. We need more Māori surgeons, you know, specialists, nurses, the whole kind of gamut of the workforce. I have a strong belief that if we have more Māori working actively in the health sector, that obviously in turn our people will engage better. That their commitment to you know, improving their lifestyle is not only just against that practitioner, but also against their whānau as well. And I do believe that Māori for Māori is clearly the approach that we need to be promoting. Not saying that, you know, if I break my arm, I don't care necessarily who necessarily fixes me, but when we're talking about long-term diabetes, cardiac, and the whole association with gout and all the other kind of respiratory related conditions, we need the Māori workforce to be able to support our people. And I mean, Rawiri is a leader and a champion in that space, and I loved his kōrero just then.
Ka pai. Hey, Look, I'm aware we come to the end of our time, and I'd just
No, we
like
haven't
to,
come to the end yet. I've got more to say. There's three
yeah,
articles already
I'd
left,
just
but
like to offer some final words. Actually, Rawiri, you can go first, and then Gilly, and then we'll.
I've got a couple more provocations. I want to pick on some Pākehā mainstream organisations just because I can. I'll give you one. We have organisations in our health system which are white supremacist, which are eugenics based, right? Truby King was a white supremacist. Truby King was he believed in eugenics. Now, I cannot change the fact that those organisations are part of our health system historically, but we can change the future. There is no place for white supremacist organisations in our health system. If you know what I'm talking about, that's Plunkett. Plunkett must be defunded. They must be wound up. They must be historic. They cannot be our future. I'll give you a different one, is Ronald McDonald House. Now, we have these things, and Ronald McDonald House, to be honest, they get to pay for the branding as if they're doing it all, but they ain't doing it all. Taxpayers, you and me, we're paying for the services that go out of Ronald McDonald House, but Ronald McDonald is getting all of the kudos for it. He's getting all of the credit for it. And the district health boards have to offer that to Māori. Why wouldn't we have said yes? If it was ever offered to an iwi, I tell you they would say yes. That's our obligation as mana whenua to do that service to manuhiri. We have all of these people living in our area. We'll do that job. Whānau House will look after these families and their kids when they come for treatment. We should be doing that, but no DHB has ever offered us the opportunity to do that. And that is a treaty right, in my view. We should be doing those sorts of things. So, yep, I want to brown up everything. I want to brown it up. I said to Canterbury District Health Board, they have 10,000 employees, but only 350 are Māori. If their 10,000 employees were as Māori as the district that they serve, they would have 1,100 Māori employees across all sorts of jobs. And that would bring $77 million into the Māori economy in Canterbury every year. You would see Māori health improve, you would see housing improve, you would see huge benefits from doing it. So DHB's number one job is actually to employ Māori. That's browning up. That's the browning up that I'm looking for. To that rangatahi, you asked the question, what should I do for the long-term health outcomes? You know, be the best that you can be. I don't mind. You want to be a neurology specialist, that's fine. If you want to be a nurse practitioner, that's fine. If you want to be an accountant, that's beautiful. If you want to be a lawyer, man, these lawyers are doing great jobs for us. And look, we got our first Supreme Court Māori judge, you know, like be the thing you want to be, love it. And number one thing is we've got to love our people.
Kia ora.
That's our job. All right. Kia ora. I talk all night. It won't help you. Good night.
Beautiful. Thank you, Rawiri. That's lovely. Gilbert, final words?
Well, hard act to follow, so I guess when we talk about equity, we need to think about equity from a treaty lens, and so that means equity not only in access but outcome. And I get really frustrated with this terminology because it doesn't necessarily still articulate the priorities that need to be placed around the fact that our Māori people still have a ways to go, and we do what we do. I think Rawiri is such a great example of a champion that is obviously trying to turn the system, but obviously is also supporting whānau in some of the clinics and the work that he does, obviously. So really, heads up to you, bro. I appreciate the work that you're doing. I understand what you're up to. I hear you were down south the other day. I'm interested about that corridor as well. But hey, I think we're running out of time.
I was in Dunedin, I saw my mokos. I took my mokopunas to their first protest. Keep the coal in the hole. We were blocking the Fonterra coal line thing, and then we got karengo, and we got cockles, and I got kina, and I got pawa. So, had a beautiful time in Dunedin. Kia ora.
Oh, you'll come and see me next time. I'm a bit upset, really, that those graduations that are planned this week have been stopped as a result of a range of bomb threats. So I'll what pain for whānau that have come from all around the country to celebrate, obviously, the work that, their moko have done. I'm gutted, and we'll see what unfolds tomorrow with the Māori pre-grad medicine. Kia ora.
Yeah, kia ora, Gilbert. Well, kia ora koutou, and thank you both for beautiful kōrero, and for everyone who joined our webinar tonight. Ngā mihi kia koutou, and I'd just like to invite Rawiri, would you close us with a karakia for this evening?
Okay, it'll be a short one.
Ka pai.
Okay, ngā mihi kia koutou, koutou I tūhono mai nei. James asked the question about the independent hauora agency, and I said yes, and. So yes, I want to see that, and we've got much more to do. And so my karakia is really thinking about how we do all of this, the complexity and the day-to-day reality, the forward vision, and understand what it is to be good ancestors. So, e pēnei ana nā kōrero, ko nā āhuatanga ki ronga, ko nā āhuatanga ki raro, ko nā āhuatanga ki waho, ko nā āhuatanga ki roto. Ko nā āhuatanga o te ao te kitia, kia tau ki rungi a tātou, te manaakitanga o nā mātou tūpuna hei arahi a tātou, tūturu whakamaua kia tīnā.
Tīnā.
Tā
Tā ie ki e.
Ka ki te koutou. Ka ki te